go off video just for the next few minutes.
Welcome to those of you that are joining us. We'll get started in just a few moments. Please feel free to introduce yourselves in the chat. A few things just to remember before we start is your cameras and microphones are disabled. Please utilize the chat function for any questions, comments, or extra support you might need. Be sure to select everyone from the drop-down when you're typing into the chat. And there's going to be 15 minutes for Q&A at the end of the presentation. If you're participating today to receive CME or CU credit, you'll need to attend for 45 minutes or more to receive your certificate, and all participants who would like to receive credit will need to complete the evaluation survey at the end of the session, which we will put into the chat. And then we will send certificates out by September 6th, along with a link for the recording of today's session, the slides, and related resources. And they'll also be on our website in the BHIPP Resilience Break archive as well. So again, we'll get started in just a few moments. Welcome, everyone. Thank you so much for joining. My name is Lily Stavisky, and I'm a part of the BHIPP team, and I'll be introducing our presenter for today and also facilitating our Q&A at the end of the session. For those of you that are unfamiliar with BHIPP, I'd like to provide some information about our program. So Maryland Behavioral Health Integration and Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals to address and manage mental health concerns. And BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination, and also training and educational opportunities. And the BHIPP Warm Line is staffed by a team of child mental health specialists and is available Monday through Friday from 9 a.m. to 5 p.m. And we will put our phone number and website in the chat for you as well. It is my pleasure to introduce today's BHIPP Resilience Break, Supporting Youth Who Experience Anxiety at School, presented by Dr. Rihanna Platt. Dr. Platt is an assistant professor, of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine. She is the medical director of the Latino Family Clinic at Johns Hopkins Bayview Medical Center. Her areas of clinical expertise include child and adolescent psychiatry, as well as adult psychiatry. Her research interests include the implementation of mental health and family psychosocial screening in pediatric primary care settings, mental health promotion within primary care settings, and Latino mental health. We are very grateful to have you here today with us, Dr. Platt, and thank you so much for sharing your expertise with us during this session. So I will pass it over to you now.
Great. Let me just get my slides up. And you put it in presentation mode.
Yeah, go to slideshow.
Yep.
Perfect.
Okay. Great. So it's nice to meet everyone, and nice to see also some psychologists here. So please feel free. We'll go over a little bit of that, but the goal of this is really to have it be helpful for you guys, and I definitely welcome questions and input either along the way or at the end. So I'm just going to go over a little bit again for those of us who joined since Lily just described, but this is just an overview of the services offered at BHIPP. So in addition to telephone consultation with a child psychiatrist, there's also support for resources and referrals, training and education like this. We have a social work program. There's a Project ECHO, which is sort of a longitudinal case-based learning, and then telepsychiatry and counseling, and then care coordination. And just to note, BHIPP is supported by the Maryland Department of Health as well as the as HRSA. And I have no conflicts of interest to disclose. The learning objectives today, so by the end of the presentation, the goal is to be able to describe different presentations of anxiety with a focus on how it might look in the school setting, talk about screening tools for anxiety, and then a couple of different approaches to managing anxiety, again, with an eye towards thinking about going back to school in the school setting. So I was going to start off with a couple of different cases, kind of illustrating different ways that anxiety might present. And then I'll come back to these cases at the end so that we can kind of think through, based on what we went over today, how we might approach some of these cases. So the first is a 12-year-old male who presents for a well child check. Growth and development, there are not any concerns, no significant psychosocial concerns. The patient has done well in school academically, but recently he started having trouble getting out of bed in the morning, and he's been starting to say he didn't want to go to school. And so this is sort of fast forward halfway through or all the way through September. He maybe missed about half of the past 2 weeks of school for these reasons. And then when he is there, may go frequently to the school nurse for stomach aches. And they've done exam, perhaps sent them to their primary care provider, and the initial workup related to that is negative. The next case is an 8-year-old female who presents to the clinic with her mom, who's noting that the patient refuses to talk at school. So while she also does well on tests, has a lot of difficulty with participation, particularly when there's group-based projects. She did interact well and spoke when she was at camp over the summer. And parents present because they're concerned that she'll be overlooked by her teachers or miss out on friendships. The third case is a 6-year-old brought in by parents because of a 1-month history of aggressive behavior in school. The teachers note that he's hyperactive and distractible, and note that he's particularly gets angry with 2 male peers. And when you speak with the family, it also sounds like those male peers have been cornering him during recess. And then the fourth case is a 6-year-old who's starting kindergarten, and the parents call because the patient has had a lot of difficulty at school drop-off. So he'll be screaming, clinging to the parents. School has started calling the family to have them pick the kid up because he's not able to calm down at school. So those, again, keep those in mind. We'll go back to them at the end and sort of apply what we talked about. So just a general overview of anxiety in children and adolescents. It affects a pretty large proportion of youth. We describe it really as clinically significant fear and distress in response to specific stimuli or situational cues that are perceived as threats. And there's sort of 3 kind of domains of the way this might present, including fear, worry, and physical symptoms, and we'll talk about that. The kind of disability that comes along with anxiety relates to typically to avoidance behaviors that start, and we'll talk a little bit about sort of the cycle of avoidance that can happen. And those, the more the avoidance happens, the fear or the worry is reinforced. And there's also a reduction in self-efficacy or ability to manage or tolerate the feared situation. So this is just as an example of what we call like an anxiety response cycle. And really the goal of looking at this is to see how it continues to sort of, if you don't interrupt the cycle, it can kind of continue to go and reinforce itself. So there may be a trigger, for example, so school, right? Anxious interpretation. And we'll talk a little bit about this because there are certainly schools where it objectively is not a safe place, which is a different issue, right? But fear, for example, if it's an unrealistic fear that school is really unsafe, anxiety increases related to this fear. They begin to avoid or go towards safety, which might mean not going to school. By not going to school, their anxiety might decrease temporarily, but then it perpetuates the anxiety and the cycle continues. So in terms of the different types of anxiety, this is just a slide going over, some of the differences. So separation anxiety being fear of loss of the caretaker, and that's most common in younger school-age kids. There's specific phobia, which you may not hear, depending on what the specific thing is that the child fears. It may be disabling or less disabling. If it's a context that maybe the kid is not really in or doesn't really have to approach during their daily life, it may be less problematic. There's social phobia, which is fear of or worries about embarrassment. And that's sort of on a continuum with selective mutism. And that would be the sort of most extreme presentation of that, in which their fear is so much that they refuse to speak. Then generalized anxiety, which is really more of the worries. So the fear is what we think about with the sort of fight or flight response, and usually sort of intense, whereas worries tend to be, they can be very intense, but they're sort of ruminating or thinking about things. Oftentimes that will happen at bedtime and might interfere with falling asleep. Generalized anxiety is also, it's not uncommon to have sort of perfectionistic traits and seeking reassurance. And then panic disorder, which unlike separation anxiety, really tends to occur adolescence and beyond. And that's really the overwhelming physical symptoms of fear. So how might anxiety, again, this is sort of similar to what I talked about, but just really thinking about what things might look like, in particular, thinking about school. So, for example, perfectionism, someone might be really concerned about the quality of their work and then not turn in assignments and sort of paradoxically end up doing worse in school because of the perfectionism. There can be rigidity and difficulty with change and routine. So that can also be really problematic, both the change of going to school and then changes that happen in school. For example, if they start having additional teachers that are in the mix or classes. There's tantrums. And that's oftentimes will happen when a child, child could have tantrums or even be aggressive. And sometimes that's in response to having to confront the thing that they fear. There's difficulty focusing. So, oftentimes, I think the first thing that comes to mind with difficulty focusing is ADHD. But if someone's worrying or ruminating about things, that can also present as difficulty focusing. Difficulty separating from caregivers, school refusal, avoidance, which we talked about, and then the somatic symptoms, which I talked about in one of the cases. So then there's also thinking about what I called sort of external sources of anxiety at school. So these are things that, objectively may be happening that may be associated with anxiety, but really the approach to it wouldn't just be on the pure sort of treatment of anxiety or the individual, but really thinking about the situation and rectifying that. So bullying, as folks know, is unfortunately highly prevalent. And then another thing to think about is learning disabilities, in which we see higher rates of anxiety disorder and higher levels of anxiety. So just thinking about school-related anxiety and what it is about school that might be difficult. So those are all a little bit about presentations. The rest of the talk is going to be more about different approaches to managing anxiety, again, with this eye on thinking about the school setting. So, just to kind of go through a couple of potential steps, I sort of alluded to this in the last slide, but assessing the source of anxiety, getting a sense of what the symptoms are, and I'll go over each of these in detail. There's the assessing for parental accommodation, and that's really important. I'll talk a little bit about it, but that can sometimes reinforce the anxiety. And so oftentimes there needs to be, in addition to working with the kid, significant work with the parents. I'll talk about a couple of behavioral and pharmacologic treatments, and then I'll go into school coordination, again, thinking about those potentially external things that are important and might need to be addressed in order to effectively address the anxiety. So the next couple of slides, I'll be talking just about assessment tools. And I think, many people, I know we pretty frequently talk about the SCARED, but it can be helpful to have multiple informants. So particularly if the child is older, oftentimes there may be a difference because anxiety, while I did say it can present with tantrums and sort of these, what we would call external behaviors, a lot of the time the anxiety is sort of really internal to the child and others may not be aware of it. So having the child report as well as the parent report can be helpful, and then sometimes the teacher report. And as I mentioned before, the source of the anxiety can influence the way we might treat it. So these are examples of a couple of questionnaires. The SCARED, as I mentioned, which screens for a number of the anxiety disorders. It doesn't assess for OCD and PTSD, but those they're sort of not necessarily categorized as anxiety disorders, but just to be aware, many people do the GAD-7, and which is obviously much briefer, but really only gets at generalized anxiety. So if there's this question around, is the source social or is the source something else, the SCARED is sort of one of the more broad versions. There's the preschool anxiety scale. So that's when you have younger kids, one to consider, and all of these are freely available. And then with school refusal, this is an example of some of the assessment scales. So this is, for those of you who haven't seen the SCARED, this is an example of some of the questions on the SCARED. So as you can see on the far right corner, it's probably hard to see, but it sort of categorizes what the different symptoms are and kind of lets you know there's both the larger overall scale and then there's subscale. So it might say their overall scale is positive and it was particularly elevated in symptoms of, for example, generalized anxiety disorder. This is the preschool anxiety scale. And this is a parent report. So, the younger the kid, the more we tend to think about parent report as opposed to the child report themselves. And then this is an example of a couple of the questions on the school avoidance scale. So again, getting a sense of how significant or severe it is in terms of how often they leave the house, but then also sort of what happens. Are they feeling, how often do you stay away from school, for example, because you feel sad or depressed if you go? So again, these are just examples to give you a sense of the types of questions that are on the screens. But again, all of the ones that I mentioned, the links are in the slides and they're all freely available. So in addition to the screening measures that I talked about, a lot of the questions that we ask related to anxiety are not dissimilar to questions that we ask about physical symptoms, right? So how often is it happening? How intense is it? Are there things that tend to make it worse? The other things that we think about a lot in terms of potential triggers might be, asking about bullying. Are there notable life events that might have influenced things? So have there been changes at home? Are there changes in the school group? Again, exposure to violence, which is unfortunately quite prevalent. And then again, asking about are there learning problems? And then this question about avoidance is important to really understand, like, what's the impact of the symptoms that they're having. And it often relates to avoidance and the things that kids tend to avoid, particularly when they're like developmentally appropriate activities or important activities that they then begin to avoid. We worry a lot about the impact. And then there are observations. So it may or may not come up in the office, but thinking about, is the parent, even in the interactions, does there seem to be, I'll talk a little bit more about accommodations, but you can both ask and also get a sense of, is the parent signaling that the situation is dangerous when maybe it's not, and how is that influencing the child's interpretation of the situation? And also, being with an anxious kid is really hard, and the quickest way to decrease the distress when you're with them is to accommodate their desire to avoid. When that happens, as I talked about, the cycle can happen again, but it's not uncommon and oftentimes important to pay attention to. So this again goes back to the parent role. And so, again, you might be, if you have a kid that's displaying, really intense anxiety, it's sort of a natural response in some ways to try to rescue them from that situation. And there are certainly situations where, again, it's objectively unsafe and we need to rescue them. But there are other situations where what the goal is really to focus on the parent supporting the child's ability to assess or to both like accurately assess the situation and to tolerate it. So this is an example. Again, this is a link to a treatment. There's been more focus on, treatment. How do we treat anxiety? And sometimes actually working with the parents. And this could particularly be the case when the kid maybe doesn't want to engage in treatment themselves, and the importance and the efficacy sometimes of even working with the parents and teaching them the skills. Because as much as we're working with kids individually, the parents are with the kids all the time. So sometimes focusing on them can really be helpful. So there's an example of this type of treatment, which is really focused on parent coaching. So, another question is really, some anxiety is normal, right? So what might be, this is really just to kind of get a sense of like, when do we become concerned? When do we have to intervene a little bit more? And so we could think about it both with respect to focus, intensity, the interference of the anxiety, and then if there's recovery from episodes. So, there are a lot of anxieties that are kind of developmentally normal in nature. So fear of bodily injury, fear of storms in elementary school, some concerns about school performance or social competence in adolescence or health in adolescence, we begin to think about it being more leaning more towards an anxiety disorder if the focus is really unrealistic in nature. So for example, and that could be either, being afraid of hurricanes and being afraid that it's going to happen and you're living in the Midwest, which obviously doesn't apply to any of us here necessarily, but thinking of examples that are really sort of either developmentally beyond what we would think are normal fears or just generally far from being realistic. Then the intensity. So some degree of distress can actually be helpful and is somewhat normal. So, I think if a child is a little bit distressed at daycare drop-off initially, for example, that doesn't necessarily mean immediately we go to thinking about anxiety disorder and treatment. But for times when they're really inconsolable, they can't calm down, and the distress really feels out of proportion to the situation, we start thinking again about disorder. The most important thing to really thinking about treatment is interference. So if the child is able to engage in usual activities and maybe their fear about school performance, for example, might be motivating. If they're doing really well, there's a point beyond which if they're so perfectionistic that they're staying up really late and not able to sleep, that's another issue, but a little bit of anxiety can sometimes help. So for example, if a child can't make friends or is unable to speak, then those social concerns are probably kind of in the realm of disorder. Again, as I alluded to before, if there's an impaired performance and concentration, again, it's influencing their academic success. And then recovery, as I mentioned, if there are sort of brief blips in anxiety and they're able to recover relatively quickly and there doesn't end up being an impact or interference, that's less concerning than not being able to recover and being continually worried about the episodes happening again, particularly if they occur in multiple settings. So talking a little bit about treatment, and I know we have some psychologists in the room, so please feel free to chime in. One of the most well-established treatment for anxiety is cognitive behavioral therapy. And these are just two examples of the way it's displayed. And so it's really this idea of how we think affects how we feel and how we act. Then what we do affects how we think and feel, and what we feel affects how we think and act. And so oftentimes, sometimes the focus of the treatment is on a different sort of part of the triangle. So for example, with generalized anxiety disorder, a lot of this where I talked about there was, a lot of rumination and worries, we might focus a little bit more on the thoughts and really like noticing thoughts that you're having, checking yourself in terms of how realistic they are, being able to challenge them. Versus behaviors, if that's really the key part, that may be emphasized a little bit more in treatment, but oftentimes some of these three kind of domains are touched upon. So, there are different, as I mentioned before, based on kind of the specific anxiety disorder, there may be some differences in the way that the treatment is focused, but typically what might be included in CBT is psychoeducation, symptom hierarchy, which I'll touch upon shortly, some relaxation training, again, those cognitive strategies that I brought up before for sort of challenging thoughts, and then exposures, which relate to the hierarchy. And as I mentioned before, so the emphasis, there may be more or less emphasis on one or other of these components, depending on what the situation is. So in terms of psychoeducation, and this is also an area where I think primary care providers can sort of start the process in terms of providing information about anxiety, both to the kid and to the families. So the idea that anxiety really is when your body is preparing for a potential threat. Some anxiety can be good. So we talked about, again, the goal is not for the child to have no anxiety, and some, anxiety can be helpful in some situations. But when it is out of proportion or there's a really strong physical reaction when there doesn't need to be. So if there's, people always give the example, right? If a tiger is chasing you, you want to have some physical reaction. You don't want that same physical reaction if it's not needed necessarily. So we talk about sometimes anxiety being sort of a false alarm. And again, you can talk a little bit about the parts of anxiety. So you can have worries, you can have these physical symptoms like palpitations or sweaty palms, and then this issue of avoidance. And then there's the idea that treatment both helps the child and family to recognize the difference between true alarms and false alarms, should be providing some skills about how to manage when those anxious thoughts and feelings come. And then I think an important thing to note is that oftentimes treatment of anxiety will involve facing the anxious situations, because we know that eventually continuing to kind of face, and I'll talk a little bit about doing it in a gradual way, can ultimately help. But I think it's important to kind of, sometimes you want to give a prelude that like it's not going to be easy, and that, you know, that's part of this idea of exposure and facing your fears is really a critical part of the treatment. So these are just examples of some potential tips for parenting an anxious child. And it's probably too small to see, but the Child Mind Institute has a lot of really good, much of their stuff is really, really targeted for parents, but they have a lot of great information on quite a range of topics, including parenting an anxious child. So again, this is some of the things that I've brought up before, but this idea that it's unrealistic to eliminate anxiety. So that isn't necessarily a realistic or helpful goal. For something, obviously, if the situation is unsafe, that's a different thing. But if it is not unsafe, the avoiding things or avoiding a situation due to fear of distress then really sends the message to the child that they can't handle the situation. So what I brought up at the beginning in terms of their sense of efficacy to manage things will actually be reduced. There's this issue of reinforcement, which I talked about, the importance of not asking leading questions about the anxiety, expressing positive but realistic expectations for the kid. So again, not kind of asking leading questions or giving them the message that they can't handle it, but not also expecting that they're going to be able to handle something to a degree that they aren't able to in the moment. There's this, and again, that the next sort of bullet is similar. You know, we want to be validating of the concerns that they're having, but at the same time express confidence in their ability to manage. There's this issue of, right, like wanting to have structure and wanting to know what's going to happen. So giving some warning with changes in routines, but you don't want to give so much warning that they're then kind of thinking or ruminating on what those changes might be. It can also be helpful, you know, to sometimes practice things ahead of time. So, you know, particularly if the child is socially anxious, talking with them about role playing the situation, or having, you know, play dates before school to kind of get them used to a few select peers that they can then feel comfortable around when they start school. So I alluded to this before, but this issue of symptom hierarchy development and exposures is an important part of anxiety treatment. So the fear thermometers really is an example of a way to sort of visually for the child give a rating of how they might feel. And they can fill out this, either the thermometer or the hierarchy, which I'll show next, based on what the concern is. So particularly with something like, you know, so social anxiety, what's at the top of the, you know, the most distressing situation, or a 10, might be like being in school and giving a presentation. And so you might not want to like give them that is something that would be, if they are able to tolerate that, and that's at the top of their hierarchy, that's really what they want to work towards. And then you want them to think about things that are progressively more challenging. And so they build up to that instead of confronting them. So while we talk about it's important to face your fears, oftentimes it's important to do so gradually. So this is an example of a fear hierarchy. So with a child with, for example, separation anxiety, you would think about different situations that are more or less distressing for the child. So starting, for example, with being apart from the parent for 10 minutes, it might be that the kid is literally not apart from the child at all. And so that 10 minutes might be a important first step. that's well before like going to school for the whole day. So these are examples of things that they might gradually be able to do and work towards. Then there's the sort of relaxation strategies. And those, I think a lot of folks have heard of, things like progressive muscle relaxation, belly breathing. One example is this idea of take 5, which I think is really nice and intuitive for a range of ages. We see it both with adults and with kids, but this idea of kind of focusing on sliding your finger up and down each digit and breathing in on one side and out on the other. And again, oftentimes these like focusing, kind of refocusing to either a physical sensation or the breath can be helpful. Then there's cognitive strategies, which I alluded to. So anxious kids can kind of repeatedly have these worrying thoughts. And so we talk about sort of different ways that they do so. So sometimes it's like catastrophizing, thinking the situation is, out of sort of proportion to what the reality is. And so it's really getting the kid to recognize, first of all, that they might be having a thought like this, and then being able to kind of stop themselves and interrupt it. And so the goal is really to, again, identify the thought, then think about, oh, is there something that might be, is there any evidence that maybe that's not necessarily the case? Can they talk back to their thoughts? And then eventually just being able to notice, okay, I'm having one of those worry thoughts again. And they tend to, over time, kind of bother the kids less. So then the next question is, and again, I know many of the concepts that I brought up might be things that happen in therapy. And so there, you could bring up the concepts, but it's not necessarily realistic for you to be doing that, for primary care providers to be doing all of those things. But, in terms of when we start to think about medications, we talk about this. This is sort of guidance that we generally give, whether it's anxiety or something else. So are there sufficient symptoms? And have they been present for a significant period of time? How much distress is there? So, for example, if a child is unable to attend school, that is really a significant departure from normal. And so if if they are really sort of down on that trajectory in terms of being able to function, that might be a time when we might think about medication more quickly. And then is there significant departure from their normal presentation? The other thing of medication is ideally thinking about, have other interventions been unsuccessful before we get to the point of medication? So just thinking about the role of medication and psychotherapy, this is really just a very brief overview, but sort of the biggest study that's been done on child anxiety treatment is called the Child and Adolescent Anxiety Multimodal Study, or the CAMS study. And that study was designed to ask this question: does medication therapy or combination treatment work better for child onset anxiety disorders? It was with a pretty large, so almost 500 kids who had generalized anxiety, separation anxiety, or social anxiety. And they found that both cognitive behavioral therapy and sertraline or Zoloft were effective in reducing the severity of anxiety, but that the combination treatment had kind of that was sort of the best response. So we often say ideally, particularly if it's severe, there are cases when you might do therapy alone. But if the anxiety is really significant, combination treatment is sort of the best, has the best evidence. So then, again, a brief, and I think we've had resilience breaks related to medication, so I won't go into a huge amount of detail because I want to make sure we have some time for questions and some time to talk through the cases. But in terms of what we use to treat when you are using medication, SSRIs are really first line. And for anxiety in particular, there's no really evidence that one is superior to others. And so sometimes we recommend, have one or two that you might feel comfortable using and titrating. This table here just kind of goes over the different FDA indications for anxiety. So interestingly, I will oftentimes use anxiety first because that it was the medication that was in that big CAMS study. but the FDA indications doesn't always map on perfectly. So it's indicated for OCD, but not, for example, for generalized anxiety disorder. On the other hand, duloxetine is FDA approved for generalized anxiety disorder, but we also know that SNRIs, which include duloxetine and venlafaxine, tend to have more side effects than SSRIs. So even though, for example, duloxetine is indicated, I would typically start with an SSRI before an SNRI. The other thing, I can't remember if I put this, so the other thing we talk about oftentimes with anxiety, particularly with kids who have physical symptoms, is the importance of like starting at a low dose and slowly increasing the dose of medication to minimize kind of the chance of having physical symptoms, because they may be more likely to have this sort of anxious interpretation of what those symptoms are. So having a stomach ache, they may be more sensitive to having those. And then this issue of like, when do we use PRNs? We're generally, I'm generally pretty cautious unless it's like highly disabling and we think maybe about very early on while you're up-titrating a medication. The concern about using a PRN is that it might reinforce the avoidance behavior, or the child may feel I can only confront this situation if I have the medication. I can't tolerate really the distress. That's part of oftentimes what's going on in the treatment. So hydroxyzine is sometimes used, just remembering the potential anticholinergic effects. And then we really try to avoid benzodiazepines if possible. And then there's this issue of school coordination. And oftentimes, a primary care provider's role or degree of involvement may depend on whether they're engaged in mental health treatment. As therapists and mental health providers, getting information from the school, coordinating the school is, oftentimes part of bread and butter of the treatment. And so, again, it's important to get a sense of if they are in treatment or receiving therapy, getting a sense of how connected to the school the therapist is. If they're not in treatment, then some of this may end up falling on primary care providers. So there's a couple of different kind of things to keep in mind. So, the school, for example, might not, if a child, for example, is aggressive at school, or has can't necessarily pay attention, and the interpretation of the school is, oh, this kid maybe has ADHD, or the kid is defiant or oppositional, they may not see that anxiety. So some of it may be providing information to the school to help them understand the situation. Again, this issue of if there's bullying, if there's a learning disability, making sure that you're assessing for that. I put here some accommodations. There's this website, the WorryWise Kids, talks about some sample accommodations that schools may include in a 504 or IEP plan. Then there's also thinking about parent advocacy organizations, particularly if the kid is really distressed or disabled. I have examples of some of those. And then this issue, as I talked about before, particularly with something like school avoidance, it's going to be important to coordinate behavioral strategies with the school. So I've had patients, for example, where they may avoid school, and the school really can be on top of calling the family, helping support them in terms of both supporting implementing a plan of gradually getting into school, but also staying on top of when they're not in school. And then here are just some resources on bullying. As I mentioned, like when that's happening, the child may be afraid of it and there's a realistic reason for it. And so we wouldn't want to just expose them to school if there's something sort of objectively unsafe that's going on. So sometimes there needs to be advocacy in that realm. So before I go to the cases, any questions or anything that I've missed in the chat I haven't seen? Otherwise, let
me look through the chat really quick, and if anybody has any questions, they can put them in the chat or the Q&A function. I think so far there's none in the chat.
So then just going back to the cases that I presented before, I thought it could be helpful to kind of walk through potentially what you might do, whether there's any further assessment you might do, if there's a thought about what the diagnosis might be, and then most importantly, what your next steps might be as a primary care provider. So as a reminder, for the first case, it was the 12-year-old who presented no kind of health concerns, has done well in school, but has recently been saying that he doesn't want to go to school in the morning, has started to miss school, and then when he is there, is having stomach aches, and notably only has the stomach aches in school and not at home. Any thoughts about what you might do with any of these questions? So in terms of further assessment, thoughts about next steps?
Feel free to raise your hand and then I can unmute you so you can speak as well.
I'm also happy to, if there aren't any suggestions, I'm also happy to walk through really like thinking again. So since I haven't heard any questions or in the chat, so again, getting a sense of, I think first ruling out, for example, if they're saying they don't want to go to school, is there a particular reason? So again, I would want to think about bullying, making sure there isn't something specific about school. And then barring that, really getting to understanding what the source of the anxiety is about the school. Does it relate to school performance? Does it relate to socializing or particular peers? Is there anything else associated with it? And then based on that, again, this sense of like, this could be kind of multiple things, right? It could be that the stomach aches that he's having are actually part of panic attacks, versus, again, it could be sort of a more generalized, it's their kind of expression of the way that they're worrying, but they're not really as intense. So, and I think for all of these in terms of assessment, it's really also getting a sense of how impairing is what's going on. So I might be somewhat worried about this kid who is at a pretty important time, right, educationally and developmentally, and is now starting to miss half of the last 2 weeks. So wanting to kind of intervene relatively soon, if possible. And then the second question, I think probably it's a giveaway saying refusing to talk at school. But this, in terms of the potential diagnosis, so any thoughts about this? So this is an example of selective mutism, which again is sort of on a continuum with social anxiety. So again, thinking about what the specific concern is and starting to gradually, and again, there is like really oftentimes there's very specific treatment. So we're not necessarily saying that you're the one implementing treatment, but knowing what might be involved. So for this, you might think about building a hierarchy of social situations. So starting with something, relatively less threatening to them, but still a little bit threatening, so that you're kind of building up their self-efficacy to manage these situations and speaking. The third case, so really the goal with this one is really, again, I guess I should wait and see if anybody wants to bring up, otherwise I'm happy to kind of talk through my approach. But the goal of this one is really to think about, sometimes aggressive behavior may actually be rooted in anxiety. And in this case, the anxiety may be, I think, getting a sense of like what exactly is happening. And so instead of going directly to something like social anxiety or assuming that they have this, if this is sort of really bullying, you'd want to make sure, get a sense of what that is first and deal with that, and then kind of see if there are symptoms that that continue. But really the importance is, I think a lot of people don't necessarily think about aggressive behavior with anxiety, but it certainly can present that way as well. And then the fourth case is separation anxiety. And so we had talked about this might be one where you would use the preschool anxiety scale and get a sense of, are there other symptoms that we should be aware of that are going on? And then this would be one where there would probably have to be a good amount of coordination between the parent and the school. So sometimes that could mean like starting with separating for increasing periods of time, which obviously also is relatively intensive for the parent and also potentially for the school. So I think we have some time for questions. So I'm happy to answer questions. Okay, I think most of the comments were ours.
I did have one question come in.
Mhm.
It's what would you recommend a PCP do, or how should we approach a situation where there is parental anxiety as well? And they said even more specifically with like school shootings and school violence, what you would recommend.
Yeah, I mean, that is really challenging because it's in some ways, you know, a realistic fear, and it's hard because it's not necessarily predictable, right, in terms of where it's going to happen. We might be able to say they're obviously too common here. The fact that they happen at all is too common. I think thinking about sort of statistically the likelihood of it happening any given day is not that high. And so I think the other question would be, so first of all, how do we talk about some of these things when they happen? And I think there's actually quite a few. I think oftentimes BHIPP has sort of guidance or resources related to how to talk about these because they unfortunately happen relatively frequently. I think we also think about you know, so while it is somewhat realistic, you also have to balance. And I guess the other question would be what the parents' response is. If it's like, we're going to pull them out of school for indefinitely, then, you know, thinking through like what might the effects be. And so there's sort of, yes, there's the risks, right, of attending school, but what are the potential risks or challenges of not attending school? But that one's really tough because, again, it's sort of a realistic anxiety.
Does anybody else have a question? We have another question about assessing for and addressing anxiety in the context of other comorbidities.
Mm-hmm. Yeah, are there ones that, so, you know, this issue of, I just want to make sure I'm answering I'm happy to, like, if there's even a specific case that would be helpful, because there are some comorbidities, you know, that there's like ADHD, there's potential ADHD, there are things like learning disabilities. Sometimes we'll see, for example, I think one important thing is to get, I can talk generally, but please, if you ask the question, please feel free to like, you know, if I'm not addressing it, to ask another one, or we can talk about a specific case. One thing that we see not infrequently is comorbid anxiety and depression, and getting a sense of the time course of that. So sometimes what we see is a kid struggling with anxiety really significantly, and then they become demoralized, and that leads them to feel depressed. So sometimes getting a time course of what's going on can help you think through, like, which one do you start with, right? I mean, if they're severely depressed, you might start with that, but you might also think, okay, if we can really get them a good course of treatment, that might actually also help with the depressive symptoms. So there's some treatments where there's, you know, some overlap. And then there's other things, for example, you know, ADHD and anxiety, where the treatments might be really different. I think for ADHD and anxiety, it's important to first getting a sense of the time course. And if the inattention is really in the context only of anxiety and they didn't have it previously, then I start to think, like, are there comorbidities, or is it actually really anxiety that's sort of presenting as ADHD? But you know, it's oftentimes thinking about what do you target first? And in an ideal situation where maybe neither of them is super disabled. I mean, there's times when it's like you need to kind of do full court press in terms of treatment, but sometimes I try to think through like, which one do we want to target first? Again, particularly with therapy, because many of the therapies are skill-based. And so if you're working on kind of too many things at the same time, it can also be kind of set you up for failure. So if there is a way to sort of prioritize one or the other based on kind of what's the most interfering, I might think about that. Did that answer the question?
Yes, it did.
Yeah, okay.
Does anybody else have a question? Oh, okay, okay, Chantel, you can unmute.
Okay, can you guys hear me okay?
Yep.
Oh, okay, so I'm very, very new to the field and of behavioral health. So I was just thinking when you were talking about what you target first as far as like anxiety or depression. So when it comes to evaluating the school, whether it's a school trigger or something that's happening in school, what do you target first? How do you know it's not a home issue that's kind of presenting in when school brought up? Like, how do you evaluate the home first? Any things that's happened, changed inside the home?
So that made me think of one case in particular where for some kids actually when the home, so I think getting a sense of like, are the situations worse in one place or another? So I'm thinking about a patient I have who actually, if you have her in the home setting, she looks quite depressed. And there's a lot going on at home. She actually does really well when she's at school. And so then we think about, and so there's a couple of things. One is like, then there's things we probably want to work on in the home. And that might be more important than this patient is depressed, but just imagining they have a lot of anxiety. Again, thinking about the source, does it relate to sort of family relationships versus if it was in school? So I think my first step would be really thinking about, does it present more in one or the other location? Did that answer your question?
Yeah, I think you're basically saying which one is worse. You would examine both, right?
Yeah.
It's presenting in school. It's presenting in school, so you would probably pay more attention to it in school. It'd be brought to a higher, more people are paying attention to it, right, in school. But then you would evaluate if it's worsened at home, and then that's where you start if in fact it is, right?
Yep.
Okay, understood. Thank you.
Okay, any other questions?
Or any other, for the psychologist in the room, any other pointers?
Okay. Well, thank you so much for this wonderful presentation, Dr. Platt, and to our participants in today's session. The recording of today's session, the slides, and a list of related resources will be available on our website, and we'll also email them to you. We will send CME and CEU certificates to participants by September 6th. Please remember to take the survey that was placed in the chat before you exit. It's required if you'd like to receive a CME or CEU certificate. Stay tuned for future BHIPP resilience breaks and other BHIPP trainings by following us on LinkedIn, Facebook, or Twitter. And thank you so much again, and I hope everyone has a great rest of their day.
Thank you. Hopefully that was okay.
That's great. Let me stop